before I start on this project, I'd really like to acknowledge the team members. This project came out of some work that Karen Robertson and Liz Lucas came to my office and suggested to me one day. They're both chronic care CNCs in the Illawarra Shoalhaven area, and they were sick and tired of having emergency department nurses whinge to them about their COPD patients and why they kept presenting to the emergency department. So they said to me, we've got to do something about this. We need to find out why they're presenting. So that was where this project was born. And Paul Vandendolder is the Director of Ambulatory and Primary Healthcare, and it's his job to collect all the data in the district, so having him on board was quite important. So I'm going to go over the background fairly quickly because I'm mindful of time, and I'm sure that we're all fairly aware of how important COPD is. It's the third in the Australasian burden of disease and ninth globally. It accounts for a significant number of hospitalisations and hospital costs. Importantly though, there's limited evidence of improved outcomes or satisfaction from hospital versus community care. So if there's limited improvements on outcomes, then perhaps we're having some misguided approaches to where we're spending our energy. But beyond that, COPD is a really significant burden, not only on the health system, but on the lives of those people who have it. It impacts on people's quality of life, their activities of daily living, and their social interactions. So what we sought to do in this project was really to look at the COPD presentations in the Illawarra Shoalhaven over a 12-month period. And we obviously selected a 12-month period because of the seasonal variations in COPD presentation. But then what we really wanted to do was to have a look at those people who had multiple presentations to the EDs in that time and have a look at why they were presenting and what we could do to improve the care they were going to be receiving. So we did this in two ways. Firstly, we did a medical record audit of the Illawarra Shoalhaven Local Health District emergency departments over 12 months, and we retrospectively did that. Then we selected those people who'd presented more than 3 times and invited them to participate in semi-structured interviews. We also included their carers in those interviews because we recognised that the carers had a really significant role to play in the management of these people with their COPD. Now, just to give you a really brief overview of the medical record data, we looked at the data between July 2014 and June 2015, and there were some 126,000 presentations in that time. When we filtered out COPD, we identified 1,128 presentations across the 12-month period. And 19 individuals had more than 5 presentations during that time, and a staggering 70 individuals presented more than 3 times. Now, because this was a retrospective audit, the data was a little bit dirty in the respect that we could only pick up people who were coded with COPD or shortness of breath or things like that. So it is feasible that people did present to the ED, but we couldn't actually pull them out because we didn't want to look through all 126,000 presentations manually. Of those 70 individuals who had more than 3 presentations, they were aged between 53 and 95 with a mean of 74 years, and about half of them were male. Now this next graph just gives you a bit of an idea of how those presentations were spread. So across the bottom of the graph we've got the number of ED presentations, and each different colour on the graph represents a different emergency department. So what you can see is that the different emergency departments had sort of quite different numbers of people, but there were still significant numbers of people who had 10, 11, 12 and 13 presentations, which is kind of scary, isn't it? 37 people sort of fell in that 3 presentation category. There were 14 people who had 4 and 6 people had 5 presentations. So it's significant numbers with those multiple presentations. Now, I don't know how well you can read the cartoon, but we've all seen in our clinical experience that there's a range of frequent flyers in our hospital EDs. And COPD in particular is a really important clinical case where you see Norm come back time after time after time. And the CNCs who guided this study really identified that their ED colleagues felt that these people presented because they had poor self-care and inadequate self-management. And that was kind of the premise, I guess, that we were looking at this study. So when we got to the interviews, we identified 32 potential participants because we checked for people who'd passed away because obviously being frequent flyers, these people were quite unwell. We also excluded those people who'd been admitted to an aged care facility and people who were currently in hospital at the time of the study. And we ended up doing 18 interviews, and 9 of these included carers. Just over half of the participants were male, which was very similar to the overall cohort of those 70 patients that we identified. And 50% of the participants were from a rural location, because the Illawarra Shoalhaven covers sort of the urban areas of Wollongong as well as some more rural areas. And we identified 5 themes from the data. And as my colleagues conducted these interviews, they identified that despite the fact there'd been CNCs working in the community for many, many, many years, some of the issues that the participants raised by these interviews were much more significant and impacting on their lives than these CNCs had ever imagined. So the first theme was about grief, loss and regret. And the depth of the grief and loss and regret expressed by the participants was really profound in this study. They described living with COPD as a living death, it being cruel, a slow death and a cruel way to live. They spoke about it being scary and frightening, of gasping for air, drowning in phlegm and feeling like they were going to suffocate. And yet, despite how affected they were, they also spoke of hope for the future. It's something we've got to live with. It's what there is. There's not a lot of sense whinging about it. I'm just hoping if I cross my fingers, I'll see the next winter out. I don't know until it comes about though. So it was quite a significant effect on them, but they still had this hope. As well as the patients who had the COPD, there was also a significant impact on the carers. They had a significant physical and emotional toll. They described how caring for someone with COPD tired them out. They just want to go away into a corner and have a few minutes peace and quiet, but they don't get it. They saw how it was frustrating to see someone that they'd lived with who was so fit and healthy now being frustrated by the fact that they couldn't do the things they wanted to do anymore. The depth of the impact was again significant, and it highlighted the unmet needs in terms of physical and emotional support for this group. The fact that the carers described things like it affecting their sleep, affecting their marriage, and affecting their whole life identified the significant issues. Now, the next theme was really around patient self-management, and this was where we sort of came up with a whole lot of issues around patients perhaps not being able to self-manage, and that might have been while they were presenting. And while we didn't actually evaluate the quality or the content of the action plans, most participants spoke clearly of having a personalised plan of what they were going to do when things got bad. I've got an action plan, it's on my fridge. And it was amazing how many of them seemed to have it stuck on their fridge, which was clearly, obviously, a good thing. But what they did seem to say was that it gets away on us. I can be fine 1 minute and the next minute I'm in hospital. And what became really clear was that the issue was accessing primary care in a timely manner. They described rapid deteriorations which required urgent treatment, and they couldn't get in to see a GP in time, so therefore they presented to the hospital. One person described, you phone them up and the best they can do is about 2 o'clock. Well, it's a bit late then, therefore we'd better call an ambulance. Another person described the feeling that if I don't go to hospital, I die, and that's it. So it was quite a difficult choice for them, but one they felt that they really didn't have a lot of choice in terms of making. But what about the healthcare experience? From the data, we identified 3 key features to the healthcare experience. The first one was really around accessing services. And a number of participants described how it was great that they had pulmonary rehab and all these options that they could go to after discharge support, but they couldn't actually get there. At our local hospital, you actually have significant distance from where you can park your car to where the hospital is. So unless you've got a partner who can drive you and drop you off at the door and then go and park and then go and pick up the car later on, they couldn't actually get to the cardiac rehab or the pulmonary rehab program. The second thing was about the stigma. A lot of these participants described how when they'd had encounters with the healthcare system, there was a lot of stigma with having COPD. They felt that they were blamed because they'd been a smoker, and they identified that, yes, they'd made bad choices, but they didn't realise they were bad choices back then, and now it was a bit too late to feel bad about it. They described a real lack of empathy and the fact that they felt judged by a number of people, nurses and doctors included, and they sort of felt like how long could they be penalised for the bad choice they'd made in terms of their smoking. But then in some kind of contrast, the last feature of the healthcare experience was really about how they felt safe in hospital. And a number of these participants described just the fact that they were in the hospital made them feel safe, that they could relax, they didn't have to worry about their medications, there was someone looking after them. And they particularly felt strongly about being able to access oxygen. And oxygen was obviously clearly a thing that made them feel so much better. One participant sort of said, you feel much safer in the hospital. And the carers also described the feeling of safety in that hospital environment. So we talked a little bit before about patients having trouble accessing the GP, but the final theme really was about the primary care experience. And participants were largely positive about the primary care experience, but identified the gaps in access, which we've talked about, and also gaps in GP knowledge. One of the carers said, the GP knows us fairly well, the family and everything like that. He's very sympathetic and he's got lots of empathy. But then others identified things like, it takes up to 2 weeks to get in to see the GP. And that was quite problematic because they needed to get in much earlier. Other participants really identified that although the GP was helpful and loving and would give them a script when they needed it, he didn't actually have the knowledge required, or he or she didn't have the knowledge required, or that they felt that they required. So they described the GP as not much that they can do for them, and described the respiratory physician in contrast as being really helpful. So it was quite an interesting way of viewing the world, that they sort of saw the respiratory doctor as being the one who was really helpful and the GP who just kind of was able to keep them on track. But interestingly, despite the fact that these interviews were done by nurses who work fairly closely with some of these clients with COPD, the story about nurses in their care was actually fairly absent. Apart from the stigma they talked about in hospitals, they didn't really talk about nurses in primary care, and we found that quite interesting. We were kind of in a bit of an awkward position because it was nurses who were interviewing them and nurses who were involved in their primary care, so it was a little bit tricky to navigate. But it was interesting that these participants didn't really strongly talk about those nurses. So what really came out of this study, I guess, is that the COPD frequent flyers do actually have reasonable self-management strategies, and they do have skills around managing exacerbations. But there's significant scope to strengthen community-based healthcare delivery and better support these patients and their carers. There needs to be much stronger integration between acute and community-based services so that these people don't fall between the gaps. And understanding the patient and carer perspectives is really essential to inform our care delivery. Without knowing what these people's experiences was, there was a tendency to judge them and a tendency to blame their representations on their poor self-management, when in actual fact, if we as a healthcare system were actually better able to provide urgent or semi-urgent interactions between primary care and these people, we might actually be keeping them in their homes rather than having them present to the ED. So understanding their experiences really helped us to appreciate their concerns and consider how we can provide the best care. And working with groups such as the COPD frequent flyers has a potential to reduce their impact on the health system, but perhaps more importantly, improve their quality of life and that of their carers. So thank you very much. I've gone through that fairly quickly, but I was just mindful that everyone was very keen to get to lunch. And for those of you who are interested in the study, it's just been accepted to the Journal of Clinical Nursing, so hopefully it will be out very soon. Thank you.